All right, welcome to the deep dive. Today, we're taking a deep dive into the world of initial ventilator settings. That critical first step in using a mechanical ventilator.
Yeah.
We've got some pretty dense medical training material to go through today.
We do.
But I'm here with our expert to help us pull out the most, fascinating and relevant bits.
Absolutely. We'll break down this complex, life-saving technology in a way that's clear, engaging, and, dare I say, enjoyable.
I love it. So before we kind of get lost in all the settings and adjustments and all the little details,
Right.
I think it's important to start with the big why.
Yeah.
When we talk about mechanical ventilation, what kind of situations are we actually talking about?
So, think about what happens when someone just can't breathe on their own.
Yeah.
Maybe their lungs are damaged, or maybe they're diseased, or maybe the muscles that help them breathe, they're just not working properly.
Okay.
And this is what we call respiratory failure. And it's a serious condition where the lungs can't get enough oxygen in and carbon dioxide out.
So it's like the body's natural ventilation system has just gone offline.
Exactly.
And that's where a mechanical ventilator steps in.
Exactly. It becomes this temporary set of lungs, external set of lungs, taking over the work of breathing and giving the body a chance to heal.
Wow.
And the goal is always to support them until they can breathe independently again.
So our source material jumps right into the nuts and bolts of setting up a ventilator. But before we even think about touching the machine itself, what needs to happen?
Well, first things first, you have to make sure the patient has a clear airway.
Right.
Imagine trying to, blow up a balloon with a kink in the straw. It's just not going to work. You need a clear pathway for the air to flow in and out of the lungs.
Makes sense. Okay, so clear airway is step one.
Yep.
And then I see they stabilize the patient with something called manual ventilation. What exactly does that entail?
It's like a bridge
Oh.
before the patient's connected to the ventilator.
Right. We need to get some oxygen into their system. And we do that using a bag valve mask
Okay.
to deliver breaths manually
Right.
while the ventilator's being prepped.
Got it.
It's really just a short-term solution to buy us some time.
Yeah, it's like giving their lungs a pep talk before the main event.
Exactly.
Okay, now I'm seeing a lot of different settings here
Right.
that need to be configured before the ventilator can actually be used.
Absolutely. And the physician plays a crucial role here, providing specific orders for how the ventilator should operate. These orders cover things like, the mode of ventilation,
Okay,
the tidal volume, the amount of air delivered with each breath,
got it.
the breathing rate, the oxygen concentration, which we call FiO2,
Okay,
the pressure used to keep the lungs open, we call that PEEP,
okay.
and any additional pressure support.
So it sounds like a complex recipe with a lot of critical ingredients.
That's a great way to put it. And, just like a recipe, each ingredient is carefully measured and adjusted to meet the needs of each patient. So the doctor kind of sets that foundation, and then the respiratory therapist, the RCP, steps in to fine-tune the rest.
Exactly. The RCP uses their expertise to, make adjustments based on their assessment of the patient and how they're responding.
Okay, so we've got the airway cleared, the patient stabilized, and the initial orders in place.
Right.
Now let's dive into the different types of ventilation. Our source document highlights two main approaches:
Yeah.
volume ventilation and pressure ventilation. Is it fair to say that choosing between these two is kind of one of the first big decisions?
Absolutely. These are the cornerstones of mechanical ventilation.
Okay.
And the fundamental difference lies in what the ventilator is controlling.
I'm all ears. Tell me more.
All right. So imagine you're filling a balloon.
Okay.
In volume ventilation, the ventilator delivers a preset volume of air with each breath.
Okay.
It's like filling the balloon to a specific size, regardless of how much pressure it takes.
Okay, so it's all about consistency in the amount of air delivered.
Exactly.
What about pressure ventilation?
So with pressure ventilation, the focus shifts to the force applied. It's like squeezing the balloon to a certain firmness.
Okay.
The ventilator delivers air until a preset pressure is reached.
Got it.
And the volume of air can vary depending on the resistance in the lungs.
So with volume ventilation, we're fixated on a consistent volume, even if the pressure kind of fluctuates.
Right.
And with pressure ventilation, we prioritize a consistent pressure, even if the volume changes.
Exactly.
What are the implications of these different approaches? I'm assuming they each have their own pros and cons.
Yeah, you're right. There are definitely trade-offs to consider. With volume ventilation, that consistent tidal volume ensures a stable level of carbon dioxide removal,
Okay.
which is vital for maintaining healthy blood pH.
That makes sense. Consistent breathing leads to consistent CO2 levels.
Right.
But you mentioned trade-offs. What's the downside?
Well, because the volume is fixed, the pressure required to deliver that volume can change dramatically, especially if the lungs are stiff or resistant. This can potentially lead to, overinflation and even damage to those delicate little air sacs in the lungs.
Oh, wow.
We call those alveoli.
So in some cases, that unwavering focus on volume could actually backfire.
That's right. It's like trying to force a gallon of water into a pint glass. Eventually, something has got to give.
Now, if I'm connecting the dots correctly, pressure ventilation would be the preferred approach when we're worried about those delicate alveoli.
Exactly. By setting a pressure limit, we protect the lungs from excessive force.
Okay.
The downside is that the volume of air delivered with each breath can vary.
Right.
Which could lead to fluctuations in those CO2 levels.
So it's the trade-off between protecting the lungs and maintaining stable blood gases.
Exactly.
It seems like there's a lot to weigh when making that initial decision between volume and pressure.
There definitely is. It's a clinical judgment call that takes into account the patient's specific condition,
right,
the severity of their respiratory failure, and a whole host of other factors.
So it's not as simple as just flipping a switch.
Right.
It's about understanding the nuances of each approach and tailoring the ventilation strategy to each patient.
That's the art and science of respiratory therapy. It's about finding that perfect balance between delivering that life-saving support and minimizing potential harm.
This is fascinating. We've laid the groundwork, but there's still so much more to unpack. We've got a whole list of initial settings to dive into, and I'm eager to learn more about how they're chosen and what kind of impact they have on the patient's recovery. We'll be back in a flash to continue our deep dive.
Welcome back to our deep dive into the world of mechanical ventilation.
We've laid the groundwork, explored the two main types of ventilation, and now it's time to roll up our sleeves and get into those specific ventilator settings.
Right. And these settings are really just a starting point. It's like a first draft that we can tweak and refine as we go.
So it's a very dynamic process, constantly adapting to the patient's needs.
Precisely. We're always monitoring, evaluating, and making adjustments to ensure that the ventilator is providing the right level of support.
Okay. So let's talk about those initial settings. We touched on the concept of full versus partial ventilatory support. Can you remind us what that means?
Sure. So full ventilatory support is like the ventilator taking the wheel completely. It's doing all the work of breathing for the patient.
So it's like a total takeover.
Exactly. But sometimes the patient still has some ability to breathe on their own, and that's where partial ventilatory support comes in.
So it's more of a collaborative effort in those cases.
Precisely. The ventilator assists the patient's own breathing efforts, providing just the right amount of support to help them along.
So it's like having a backup singer for your lungs.
I like that analogy. And the choice between full and partial support really depends on the patient's condition, and how much assistance they need to maintain adequate breathing.
Now let's go back to one of the settings we briefly mentioned earlier, respiratory rate. We know the ventilator breathes for the patient, but how do we decide how often it should do that?
Right. So the goal is to mimic the natural breathing rhythm as closely as possible while ensuring that the patient is getting enough oxygen and eliminating enough CO2. And that's where a measurement called PaCO2 comes in.
PaCO2, that rings a bell. Can you refresh my memory?
Yeah. It stands for partial pressure of carbon dioxide in the blood. It's essentially a gauge of how well the ventilation is working in terms of CO2 removal.
So if the PaCO2 is too high, it means the patient isn't getting rid of enough carbon dioxide.
Exactly. And remember that feeling you get when you hold your breath for too long?
Yeah.
That's your body's way of telling you that your CO2 levels are rising.
I see the connection. So we're using the ventilator to help the patient exhale that CO2 and avoid that buildup of acid in the blood.
Precisely. And if the PaCO2 is too low, it could mean that the ventilator settings are too aggressive.
Okay.
Or the patient might be breathing too fast on their own.
So it's a balancing act, finding that sweet spot where CO2 levels are just right.
You got it. And that's why monitoring PaCO2 is so crucial in mechanical ventilation.
That makes perfect sense. Now, what about tidal volume? That's the amount of air delivered with each breath, right? How do we determine that initial setting?
Right. So remember, we want to deliver enough air to inflate the lungs properly, without overdoing it. The initial target is typically between 6 and 8 milliliters per kilogram of ideal body weight.
Ideal body weight? Why not just actual weight?
That's a great question. Using actual weight could lead to overinflation, especially for patients who are overweight or obese. Ideal body weight takes into account their height, and build to estimate a healthy rate range, giving us a more accurate target for tidal volume.
So it's like tailoring the setting to the patient's unique physique.
Precisely. We want to make sure we're delivering the right amount of air for their body size.
Now, you mentioned earlier that factors like leaks in the circuit can affect how much air actually reaches the lungs. How do we account for that?
Well, we have to be vigilant. If we detect a leak, we need to find the source and fix it promptly.
Right.
A significant leak can dramatically reduce the tidal volume delivered and compromise the effectiveness of the ventilation.
So it's not just about setting the number on the ventilator. It's about ensuring that volume actually gets to where it needs to go.
You've hit the nail on the head. Precision is key in mechanical ventilation.
All right. Moving on to the dynamic duo, FiO2 and PEEP. These settings work together to improve oxygen levels in the blood, right?
Exactly. FiO2 stands for fraction of inspired oxygen. It's essentially the concentration of oxygen being delivered. It's expressed as a percentage, and room air is about 21% oxygen.
So an FiO2 of 40% means the patient is getting almost double the oxygen they would get from just breathing room air.
Precisely. And PEEP, which stands for positive end expiratory pressure, helps prevent those tiny air sacs in the lungs, the alveoli, from collapsing at the end of each breath.
Why is that important?
Well, think of it like keeping a balloon slightly inflated even when you're not blowing into it.
Right.
When alveoli collapse, they can't participate in gas exchange.
Okay.
Meaning less oxygen gets into the blood.
So PEEP helps keep those alveoli open and ready for action.
Exactly. It's especially helpful for patients with conditions like ARDS, where the lungs are very stiff and prone to collapsing.
Okay, so Fi2 determines the oxygen concentration, and PEEP helps keep the alveoli open. How do we decide on those initial settings?
Well, if the patient was on oxygen therapy before going on the ventilator, we'll often start with similar settings.
But what if there's no prior information to go on?
In those cases, a common starting point is an FiO2 of 40% to 60% with no PEEP. We then adjust those settings based on the patient's response, aiming for the lowest FiO2 and PEEP that maintain adequate oxygen levels.
So it's a bit of a dance, constantly adjusting to find that sweet spot.
That's a great way to put it. It's all about finding the right balance, enough oxygen to support the body, but not so much that it causes harm.
Now, I'm curious about pressure support. We touched on that earlier, but can you elaborate?
Sure. Pressure support is a fantastic tool that helps make breathing easier for the patient.
Okay.
It's like giving them a little boost with each breath.
So it assists their own breathing effort.
Exactly. It helps them overcome the resistance of the breathing tube in their own airways, reducing the work they have to do to breathe.
So it's like power steering for the lungs.
I love that analogy. And pressure support can be especially helpful during the weaning process, when we're gradually reducing ventilator support and helping the patient transition back to breathing on their own.
All right, so far we've covered respiratory rate, tidal volume, FiO2, PP, and pressure support.
Yeah.
What else do we need to consider when setting up the ventilator?
Well, we've got a few more key players: flow, sensitivity, and flow pattern.
Okay, let's break those down. What is flow control?
So flow refers to how quickly the air is delivered during inhalation. It can affect patient comfort and how well their lungs inflate. Think of it like adjusting the nozzle on a garden hose.
So a wider nozzle allows more water to flow out faster, and a narrower nozzle restricts the flow.
Exactly. We can adjust the flow on the ventilator to achieve a desired ratio of inhalation time to exhalation time.
Now, what about sensitivity? That sounds intriguing.
Sensitivity determines how easily the ventilator responds to the patient's own breathing efforts. It ensures a smooth transition between the ventilator's breaths and the patient's own breaths.
So if the patient tries to take a breath, the ventilator senses that effort and kicks in seamlessly.
Precisely. It's all about synchronizing the ventilator with the patient's natural breathing rhythm.
That makes sense. And finally, we have flow pattern. What does that refer to?
So flow pattern describes the shape of the airflow delivered during each breath. It can be constant, like a square wave, or it can gradually decrease, like a decelerating ramp.
So it's not just about how much air, but also how it's delivered over time.
You got it. Different flow patterns can have subtle effects on how the lungs inflate and how comfortable the patient feels.
Wow. We've really covered a lot of ground here. It's impressive how much goes into fine-tuning this life-saving therapy.
It definitely is a complex process, but the goal is always the same: to provide the best possible respiratory support for the patient and help them on the road to recovery.
Well said. Now, I know we've thrown a lot of technical details your way, but I hope you're starting to see the bigger picture, how all these settings work together to create a symphony of care.
Absolutely. It's like an orchestra, with each instrument playing its part to create this harmonious whole.
Exactly. And speaking of harmony, we can't forget about the human side of mechanical ventilation. After all, these machines are ultimately helping real people through a very challenging time. We'll be back in a flash to explore that aspect of the patient experience and delve into the future of this incredible technology. Welcome back to the deep dive. We've been unpacking all the complexities of mechanical ventilation, from the initial setup to all those critical settings.
Right, we've explored the science, the technology, and all that, careful decision-making, all involved in using these life-saving machines.
It's been fascinating to see how each piece of the puzzle fits together. But I think now it's time to maybe shift our focus a little bit to the human experience, at the center of it all.
Absolutely. That's a crucial point. We can get so caught up in the technical details that we forget about the person on the other end of that breathing tube.
Exactly. So let's talk about what it's actually like for a patient to be on a ventilator. Can't be a very pleasant experience, right?
It's definitely not a walk in the park. Imagine not being able to breathe on your own, having a tube down your throat, and feeling that mechanical whoosh of air being pushed into your lungs.
Yeah. It sounds so disorienting and probably a bit frightening.
Absolutely. It's a very vulnerable position to be in. And that's why, communication from the care team is so important.
What do you mean by communication? It's not like the patient can easily talk back.
Right. That's true. But communication goes beyond just words. It's about explaining what's happening, why the ventilator is necessary, and reassuring the patient that they're not alone.
Yeah.
It's about creating that sense of trust and understanding.
And that's where those nonverbal cues come into play.
Yeah.
Like, paying close attention to the patient's facial expressions, their body language, all that stuff.
Precisely. Even a slight nod or like a furrowed brow can tell us volumes about how the patient is feeling.
Wow.
We're constantly looking for any signs of, discomfort, anxiety, pain, so we can adjust our care accordingly.
So it's about seeing the patient as a whole person, not just a set of vital signs or ventilator settings.
Exactly. It's about recognizing that each individual has their own, fears, anxieties, coping mechanisms.
Now, along with clear communication, I imagine comfort is a pretty high priority for patients on a ventilator.
Absolutely. Being on a ventilator can be both physically and emotionally taxing. That's why we take this, multifaceted approach to ensure that the patient is as comfortable as possible.
What kinds of things do you do to kind of prioritize comfort?
Well, we might use sedation to help the patient relax and tolerate the ventilator.
Right.
We also pay close attention to their positioning, making sure they're not lying in a way that causes pain or discomfort.
But I imagine too much sedation could be a problem.
You're right. It's a delicate balancing act. Too much sedation can delay weaning, but too little can leave the patient feeling agitated and distressed. It's about finding that sweet spot where they're comfortable but still able to participate in their recovery.
So it's not just about, throwing a blanket over them and dimming the lights. It's a much more nuanced approach.
Exactly. We also focus on things like oral care, to prevent dryness. And we really encourage family members to visit and provide that emotional support. Sometimes simply having a loved one hold their hand can make a world of difference.
It's about creating a humane and supportive environment during a very challenging time.
Absolutely. Now, I know we've been talking a lot about the present state of mechanical ventilation, but, I'm really excited about what the future holds.
Oh, tell me more. Where is this technology headed?
Well, one of the most exciting areas is personalized ventilation. We're moving away from that one-size-fits-all approach. We're developing ways to tailor ventilator settings to each patient's unique lung characteristics. It's like having a custom-made suit for the lungs.
That's incredible. So instead of relying on those, general guidelines, we'll actually be able to fine-tune the ventilation strategy based on their individual needs.
Exactly. We're also seeing advancements in non-invasive ventilation, that uses masks or nasal interfaces instead of breathing tubes.
Right.
So it's a less invasive way to provide respiratory support for patients who don't require full mechanical ventilation.
Yeah, that sounds like a much more comfortable option. And potentially, less intimidating for patients as well.
It definitely has its advantages. These advancements are all about improving patient comfort outcomes and their overall quality of life. It's amazing to think about how far this technology has come and the potential it has to transform respiratory care.
I agree. And I think it's important to remember that all of this innovation is ultimately driven by a desire to help people breathe better and live healthier lives.
We've explored the why, the what, and the how of mechanical ventilation. But as we wrap up this deep dive, I want to circle back to our source material, that medical training document.
Yeah, it's been our guide through this complex world.
It gave us a framework for understanding the nuts and bolts of setting up and managing a ventilator.
But it also highlighted something that really transcends those technical aspects: the importance of teamwork, communication, and compassionate patient-centered care.
Yeah, and those are principles that extend, far beyond just the realm of respiratory therapy. They're really at the heart of all good healthcare.
So as we conclude our deep dive, I want you to consider something, the power of the human breath, how something we often take for granted can become such a struggle, even a matter of life or death.
Right.
And how this incredible technology that we've been discussing can step in as a bridge, a lifeline to help people regain that vital function.
It's a testament to human ingenuity, our compassion and our unwavering pursuit of better healthcare.
Absolutely. Thank you for joining us on this deep dive into the world of mechanical ventilation. We hope you've gained a new appreciation for the science, the technology, and most importantly, the human stories that breathe life into this remarkable field.